the relationship with her parents, I don't think anybody would argue is a central theme to the film. Okay. Thoughts?
They're very dismissive of her. Almost, I would say, negligent to the point that she's like going outside and exploring without them, and she's, you know, not an old enough child, I think, to be wandering woods by herself.
So, would it be fair to say neglectful?
Yeah.
Yeah.
All right, and as a result, if you look at what this character experiences, and if you poll 99 people, undergraduates that are not in medical school,
Mm-hmm.
would the consensus be that this character is struggling with a mood anxiety spectrum or a psychotic dissociative if she verbalized everything to you that you observed in the movie? Hey doc, I'm having these experiences where I'm going into and out of my wall, and I visit in other verse. A or B? You can't say C.
B.
B? Right? Anybody have a problem with that? Now, what we're doing is building a case formulation, and these same steps I would ask that you apply to your real patient scenarios. It's
I
a
would
very-
say this was also very well demonstrated, which the one person she did like fully tell this to was Wybie, and he immediately was like, "You're crazy," and left the building. So,
when we choose B, we have to now pick one illness from which to work. And that illness should be non-patient specific and non-film specific. Meaning you should choose this illness all the time. And it's arbitrary. There's really, again, what we're doing now is arbitrarily choosing the illness that we want to work from when we think we are dealing with a psychotic dissociative spectrum. Thoughts? What illness do you think is a good place to start?
Probably psychotic.
Which one?
yeah, so basically what's the differential for psychosis?
What's the first illness that pops in your head?
Schizophrenia.
Let's do that. All right. Next step is to demonstrate to me your knowledge of the DSM. Give me the 5 inclusion criteria that defines schizophrenia.
I'm blanking. Flat affect is one I would.
Negative symptoms including a flat affect. 1.
The opposite of negative.
Positive. Hallucinations, delusions.
3.
Disorganized behavior.
4.
Disorganized thought.
Perfect. We'll pause. Let's reflect back on our film. At this point, does Coraline or is Coraline ruling in?
Sorry, what did you say?
Is Coraline ruling in at this point?
Not. I don't think she had any negative behaviors, did she? I could be
Well, how
wrong.
many do you need?
Oh, okay.
She's having hallucinations and delusions.
Yeah.
Is Coraline
One
ruling in?
Yeah.
She is. All right, allows us to continue. This is the point in our case formulation that we appreciate that this diagnosis, schizophrenia, is a diagnosis of exclusion.
Mhm.
So now you have to tell me the 5 illnesses to consider that we have to rule out in order to continue with schizophrenia as our provisional.
Psychosis due to an underlying medical condition, maybe?
Psychosis due to a substance.
Psychosis secondary to a mood disorder?
Schizoaffective disorder and an autism spectrum disorder, ASD. First question. Coraline appears to have a past psychiatric history of an autism spectrum disorder. A, yes, B, no, C, doesn't matter.
No.
No?
So, I mean, I would say we are given so little information about like her past. Like as far as social goes, she is shown to have a couple of friends from her past. We don't know if those are just her two best friends, but she also, you know, is socially adept with other people in her school, but she just isn't keeping in contact with them, or if like those were really her only friends. So, some limit in information.
A, B, or C? So A is right, but there's actually a better answer, right? In your medical world of test taking, I'm asking for the single best answer.
I would say she also makes good eye contact with people and things like that. So I would probably say no ASD. But I don't think you're going to go that way.
I think A. You said A.
I said B. I said no is.
Yeah. So
Yeah.
I'm sorry. I'm
Sorry.
thinking no is A. The consensus is B, and that is a correct answer, but it is not the single best.
Doesn't matter.
Doesn't matter. Right? The reason why an autism spectrum disorder is in the differential here per the DSM is because of the overlapping signs and symptoms of these two conditions. Individuals who have an autism spectrum disorder or ASD have clinically impairing deficits in communication and behavior, which can be misinterpreted as two positive symptoms of schizophrenia. So with someone who comes in who's grossly disorganized and has looseness of associations, but has an established ASD, guess what? The signs that you're identifying are due to the pre-existing condition, the ASD. However, even in someone with a pre-established or pre-existing ASD, if there are new onset delusions, new onset hallucinations, they're not going to be justified or they're not going to be explained by the autism spectrum disorder, so it doesn't matter. Because we've already established that Coraline is delusional and she is suffering from perceptual disturbances, both of which are not explained by any pre-existing ASD, so it really doesn't matter. Right? So, and that's something to remember for your shelf exam.
Can I just clarify that point with you, if that's okay? So in ASD, we're not expecting people to actually be experiencing hallucinations or delusions, but presentation of someone with hallucinations and delusions might be similar to somebody with ASD.
No.
Okay.
The first part is exactly accurate.
Okay.
Somebody with established ASD who is also presenting with hallucinations and or delusions should not have those signs attributed to the ASD. They are not accounted
Gotcha.
for by it.
Okay.
That's why it doesn't matter here.
Gotcha.
Right.
Okay. Thank you.
If Coraline were instead presenting with grossly disorganized behavior or disorganized speech or thought process, and there was evidence that she had pre-existing ASD, you know what? We think that this is due to the ASD, right? That should be our provisional thought as a clinician. But in this case, that is not what's happening.
Okay.
Right? So it's really C, it doesn't even matter. So I agree with you, the answer is really B, no. But it really doesn't matter, and that's important to remember for the shelf exam.
Okay.
All right, so next question. Is there discrete evidence, if you could look at the script, is it literally written that Coraline has an underlying medical condition? Is there anything physically going on? Is there anything that would end up on her axis 3 when there used to be an axis 3 at all?
I would say at one point, and I think depending on your interpretation of this, she does have red spots on her hand that she attributes to like poison oak.
Yeah.
Yeah. So I would want to make sure, and that's a great point, that this is in fact contact dermatitis, and it is not maybe like a neurocutaneous syndrome that might also explain her perceptual disturbances. So the answer is yes, there is something here. Whether it's truly causal, probably not, but it's worth investigation, right? So we're going to keep psychosis due to an underlying medical condition or another medical condition in our differential. It's probably low, but it belongs there. Is there discrete evidence in the script of Coraline having a substance use disorder? Now, substances here can actually be drug, illicit or prescribed, toxin, herb.
I would say that she recently moved into a new, very old house, so there could be some new exposures there. She seems to be around a wide variety of plants, so there could be some new exposures there, but it doesn't seem like there's anything glaringly obvious.
Great. So there's something in the script. And again, I think conservatively, we're going to keep this in our differential, probably low.
Yeah.
But it belongs in the differential.
I'd say there are a number of herbs and things around, even though her parents don't really garden much themselves. They do know a lot about herbs and plants and gardening.
Definitely agree. Is there a mood component to what is going on here? Because if your answer is no, then we remove both a primary mood disorder with psychotic features as well as schizoaffective from our differential. The answer is yes, we have to keep them in the differential as well.
I would
So,
say yes.
Yes? Consensus? Yeah? All right, well, we have reviewed everything with regard to those conditions we must investigate and rule out, and we have not been able to rule out a single one of them.
Mhm.
So right now, where we are in our case presentation is that we have a 11-year-old girl, who presents with what appears to be a neurobiologically mediated psychotic disorder, ruled out schizophrenia. However, we cannot definitively rule out that her condition is the direct physiologic effects of a substance or another medical condition. And given her clinically significant mood component, schizoaffective disorder, as well as a primary mood disorder with psychotic features, must also be in our differential. That's the way I would summarize where our case formulation is right now. Next step is, given everything that I just mentioned, schizophrenia, schizoaffective, substance, mood, GMC, or another medical condition, if you were to have taken notes and crossed off everything on your paper that would be explained by everything that I just mentioned, would there be anything left? Because if the answer is yes, then we have to find a condition that explains it. That is, we have more discussion. We have to have more discussion and broaden our differential diagnosis.
Quite a leap. But I think potentially, if you were saying that the rash on her hands is due to something like porphyria, some new exposure could have triggered that, and there could be some psychosis associated.
I don't think that's needing to broaden our differential. I think that's continuing to investigate what we already stated, which is we have to make sure this rash is truly contact dermatitis. So I don't think we need to broaden it. I think that's already included in where we are right now.
So I have one, and this is my...
Okay, before you go there,
okay.
let me bring you up to speed. We're discussing a case of Coraline, an 11-year-old girl who presents with apparent fixed beliefs of her visiting the other world, or the other verse, as well as related perceptual experiences. And as such, we believe she's suffering from a psychotic dissociative spectrum, for which schizophrenia is a diagnostic consideration.
Right.
In discussing this case as one of schizophrenia, we appreciate that this condition is a diagnosis of exclusion, and we also have to consider a primary mood disorder, which we cannot definitively rule out. And due to her significant mood component, would also need to consider schizoaffective.
Okay.
We have also not been able to definitively rule out that everything she's experiencing isn't due to the direct and physiologic effects of a substance or another medical condition. And although there may or may not be evidence of an autism spectrum, investigation of which the clinician must consider with regard to the differential of schizophrenia, The preponderance of perceptual disturbances and delusions is not one, or are not symptoms that we would necessarily attribute to a pre-existing ASD if one were to be established. Right. Everybody agree with that summary? In this part of our formulation, we're at a point where we're going through the mental exercise that if we had taken notes on our patient, which is what doctors usually do, and if we would cross off everything on our paper that would be justified or explained by everything that I just mentioned, schizophrenia, schizoaffective, substances, medical conditions, and primary mood disorder, might there be anything left? Because if the answer is no, we're done. If the answer is yes, there's some stuff left on my notes page, Doc, that isn't explained by anything we've already discussed. We need to have further discussion. That is, we have to create additional differential diagnoses. And that's where we are right now, to catch you up to speed. Okay? Any questions before we proceed?
I think I'm okay right now.
You're on.
So, for other medical conditions, so I was thinking through it, and there's so much like imagery for insects and spiders in this movie, especially like with her hand and the like when that comes off, looking very much like a spider, and she looks very much like a spider. So I was thinking about spiders, and I was like, okay, like, would any spiders possibly cause psychosis or delirium? And it turns out the only one I really saw was black widow spider. And I was thinking, that's interesting given how she like points and says like black is like the classic for like the buttons, and like her like black hair, and like being a woman like black widow. So next I was thinking, okay, well, would this even be plausible? Like she does have like the redness on her hand. Black widow bite would cause erythema in the spot. And then I was thinking, okay, what about location? Like do black widow spiders even exist there? Well, so she had just moved to Oregon. And actually it turns out that the studio that does like the art for this is based in Oregon. And that's like why they chose there. So interesting. Black widows are, until very recently, they were the only poisonous spider in Oregon. And where they are, where it takes place is like Ashland, Oregon, which is specifically in the southeast, and black widow spiders are only in the south of Oregon. So I was like, wow, this is all adding up like too interestingly. So, you know, she is in a new place, she's exposed to new things. She picks up a stick. I mean, who's to say in the woods, like, there couldn't have been a spider on that stick?
You kind of alluded to it as well, but Beldam is a metaphor for black widow as well, right?
Oh, I didn't know that. Okay, yeah.
Not the spider per se, but the metaphor of black widow.
Right, yeah.
The Beldam. Right?
That's, yeah, with like the black of the buttons and her black hair and everything else.
I did not watch this movie for this particular discussion. I certainly watched the movie on multiple prior occasions. I do seem to remember there being a scene or multiple scenes with an hourglass. Am I thinking of a different movie? Am I wrong?
I don't remember. I wasn't paying attention.
I'd have to check it out, which of course would be a further metaphor with regard
With
to
the
the mark.
the mark. Yeah, I'd have to look back at that.
Somebody need to Google that at some point today
Yeah.
to see if you're not thinking of a different movie.
Yeah.
So what we're dealing with then is that due to another, well, I guess, again, the distinction is artificial. Is it an underlying medical condition, or is
Versus
it a
the
toxin
delirium,
exposure,
yeah.
right? It's hard to argue against that. Black widow bite. Any other thoughts here? One of the things that came up in last evening's discussion that was admittedly with a different film was the difference between the book and the movie and how that might inform a clinical opinion. That is, when the director adds to the book, why would they do that? And in our own little narcissistic world, maybe they're doing it to make a point. And maybe we could play psychiatrists and think that it's a form of sublimation, artistic expression. of something that they're trying to discharge that otherwise they would not be able to, right? Sublimation, ego defense mechanism. Bottom line here is that when we see a difference between scenes in a movie, content in a movie versus a book, it might be areas to look and further investigate with regard to quote unquote what is really going on. And one of the departures the film takes with regard to the movie is the creation of Wybie, who doesn't exist in the book. Why would the director do that? And the answer, well, let me ask. Let's sit here for a second. Any conspiracy theories here?
I mean, I'm just gonna be cynical and say that maybe a movie just about a girl wouldn't sell as well, and they needed a young boy figure to market better to both boys and girls.
It could be. I tend to disagree with you, but that's my frame of reference. I agree with you, and no, I shouldn't say that. Let me backtrack. I absolutely agree with you with regard to that being perhaps the producer's mindset.
Yeah.
I actually agree with you. From my limited audience perspective, for me personally, I think this character actually detracts from an awesome female character.
Oh, I agree.
That's only my opinion.
He kind of takes away like some of, like he has to save her when she's in the like little room that's separated, and you know, he keeps saving her, which, you know,
But
is a thing they like.
it is. But I want to do a complete 180 on this, and that it would be even a 360. I'm getting my geometric shapes up here. I submit that Wybie doesn't even exist. So it is Coraline the whole time, right? And I think the choice of name is very revealing here. What about that?
She at one point says to him, like, why were you born? Like, why born? Which could be a reflection of some thoughts that she either has or has heard about herself. And I think that kind of goes along with maybe a potential purpose of the Wybie character as almost like, Coraline kind of can use him like as a way to like do some reality testing, and she sees the bad things that can happen in this other world happen to him before they happen to her.
I think like it's also interesting because her complaint of him is that he talks too much, and that's the complaint that her parents have for her all the time. Why don't you be quiet? Like he's a bit like, after this, don't bother me, don't talk.
The purpose of the imaginary friend is to actually then assume the attributes that are too threatening to admit with regard to yourself. I talk too much, my parents don't want me. Why was I born? Right? A child is not able to tolerate that. Right? An adult has a difficult time tolerating that. A child cannot tolerate that. So the creation of the imaginary friend is to ensure that these issues are in fact addressed, but in a very safe way.
Well, and also that he's not allowed in the house because it would be dangerous. And like her interaction in the house is with her parents, and I think she feels some danger there.
She definitely does.
Yeah.
Yep. So the whole focusing on a character that exists in the film but not the book reveals and further supports that Coraline is a movie and therefore a fictional case account of severe child neglect. Even so much as that the character of Coraline doesn't feel safe in her own home. Is there further evidence of that? Because now, as soon as you recognize this, you get to rewatch this movie, specifically looking for details that you otherwise wouldn't look for. And normal people, as they watch movies, never consider. But since you recently watched this movie, you can kind of recollect and think this through. Is there any other scenes in this movie that would suggest that Coraline is in danger? Other than the devil, right? Obviously, that's obvious.
So I was curious about in the beginning, and it seems out of place for like what they're sort of setting up in the obvious, when the mom has the neck brace and like why she has it. And as soon as she brings it up, Coraline is immediately like, but it wasn't me that caused the accident. And so it felt a bit out of place. And so I think that draws attention to it.
Yep. Why, do we know any further details about the prior MVA?
I don't remember. I was trying to watch for any other details, but I didn't pick up on any.
How many people were in that car?
I think it was just her and the mom. Yeah.
So let's twist that a little bit, and let's say that somebody presents to Robert Wood, single car accident, we're called in for rule out acute stress disorder. What is one of the first things, or maybe one of the things that would be on the top of our clinical agenda when we provide a psychiatric evaluation as a consultant? Single car accident, rule out a acute stress disorder.
I guess wanting to know if there are any like substance use involved.
BAL 0, patient denies any use of current or recent use of alcohol or illicit substances, urine drug screen negative.
Any intention to harm self or others?
Single car accidents for a CL psychiatrist are always suicide attempts until proven otherwise. You've got to enter into that room, you've got to go into that psychiatric evaluation with the idea that this was a suicide attempt, and then have the patient's report, collateral reports, the police report convince you otherwise. Is that what happened here?
I mean, I would think not necessarily possible suicide for the mom. The mom seems to like herself. But when you're thinking about, does Coraline feel safe at home? Maybe the mom got so angry in the moment that she could have done it intentionally, maybe even hoping that Coraline would be hurt in the process. But then she got hurt herself, and that's why she feels such anger and blame towards Coraline.
Absolutely an area for further investigation, right? If we had a chance to speak to mom and to not bring this up would be negligent, right? It would be bad practice.
And it's interesting too, because now thinking back, that imagery of kind of the neck injury, the band around the neck definitely comes back when the key to the little door is like Coraline's being dragged by her neck with that key and is left with a pretty noticeable like red ring.
Mm-hmm. Definitely an area of further inquiry, absolutely. Anything else? Any other, again, excluding the Belgium, which is an over-the-top yes. Any other evidence, if we are going to rewatch this film, that Coraline's home environment is in fact unsafe?
I think there's a question of food security
Yeah.
for her. They, in the beginning of the movie, were, you know, their dinner was like pretty sad and like not a whole lot, and Coraline didn't really want to eat. And then immediately when she goes into the other world, the first thing they do is sit down to this elaborate kind of meal that's a production, and there's, I think there were like trains and stuff on the table, and it's this kind of joyous occasion for her. So it seems to be something that they don't get all the time.
And later on when the mom is like, oh, how would you feel about like a mustard, basically all condiment sandwich?
Right.
Yeah.
So a couple of thoughts about that. One, what's the parallel in medicine, in the hospital?
A food security?
Yeah. Like, maybe outside of a psychiatry clerkship. Have you ever heard of this before, where this became the focus of your clinical attention, perhaps during another clerkship?
If someone's MPO?
Yeah. Right? I mean, sometimes we even consult nutritionists
Mm-hmm.
with regard to making sure that the individual is taking in the proper amount of calories. I'm not talking about someone with established anorexia where you're doing a calorie count. I'm talking someone who you're worried about the catabolism resulting in starvation and muscle breakdown. So there's a parallel here. That's something to keep in the back of our mind, because we might want to take this tangent and think about the metaphorical nature of what is really going on with Coraline. And is what we're seeing real, or is it some type of an altered state of her consciousness? So something to consider. The other thing I want to talk about, again, there's a couple of ideas that I had, given what you said about food security, is that maybe the director was trying to tell us something with regard to these scenes that were really focused on the kitchen. Was there any other reveal in any of these scenes? And more specifically, was that reveal further evidence of this little girl feeling unsafe? Because I think you're right. I think food security is a major theme in this movie, and I think it focuses our attention on this particular setting, specifically the kitchen. And she does reveal something to us that I think a normal person, viewer, would readily dismiss. But now I think this group has to kind of refocus on it. Any thoughts?
When she says, as a doll, do you think they're trying to poison me?
No? Car accident at work.
Yeah,
Let's go to plan B.
yeah.
Now, that's not an impulse that a child is going to allow to come to conscious expression. So she discharges it in a safe way and asks her doll, which, by the way, is exactly what we do in clinical practice when we ask those tough questions to children, right? Neglect, abuse, play therapy, doll therapy. And she asks the doll what is on her mind. Well, not what is in her subconscious, that her superego will not allow to come to mind, right? Discharged in a distorted way through animism. Do you think they're trying to poison me? So we have evidence that there was a quote-unquote single car accident. Well, no, it was a single car accident right in Nepal, right? Not exactly sure what that's about. Absolutely the focus of continued inquiry. And now, suggestion that maybe she's being poisoned as well. So, any further thoughts about this? If she is being poisoned, if the car accident resulted in some trauma, that perhaps would be a biological predisposing factor. The poison may be a biological precipitating factor. What might actually be the behavior then that becomes the focus of our clinical attention? And the hint is that it actually approaches this psychotic dissociative spectrum through the underlying medical condition. What might this medical condition be referred to?
Delirium.
Yeah. Coraline may in fact be a case study of delirium.
Mm-hmm.
And I would suggest that her going into and then out of the other verse is that waxing and waning that we discussed this morning on rounds. Right? If we saw Coraline when she's in her bedroom, it would be very similar to a patient that is sitting up, awake, and alert when we see them at 11 a.m. On the other hand, if we met Coraline in the other verse, I would suggest that would be synonymous with our seeing the patient at 11 p.m. when they're needing to be provided a PRN medication to address their combativeness and their agitation. That's the lyric.
I think it's interesting to note sort of the mom's behavior, like with the gloves, she ended up getting Coraline the gloves as a gift. And when you think about somebody who is abusive, they might at some point feel guilty and respond by giving gifts or like lavishing some sort of affection when, their mood sort of shifts. And the mood definitely shifts when the parents get funding. So it almost seems like maybe, and the whole thing ends in the parents' eyes when they've come back from getting funding and they're excited and wanting to celebrate. And so it seems like if it is a case of the mom sort of kind of taking out her stresses and her issues on Coraline, once those are relieved, Coraline's stressors are also relieved.
Let's talk about that a little bit. Let's clarify that. So we understand the scene that's being described, right? In describing the mother's behavior with regard to, I think, the words you used, quote unquote, taking it out on Coraline. Again, what clinical terminology might we use here?
This could be like Munchausen's, like factitious by proxy.
Yeah. Right, so that's a concern here. The film Coraline may in fact be a fictional case of factitious, formerly known as by proxy, DSM-5, imposed on another.
Mm-hmm.
Now, if we got to talk to Coraline's mom, and we didn't find any external incentive for her behavior, then that would certainly support this idea of factitious disorder, right? Because the motivating factor of why a mother would do this would be subconscious by definition. However, if we found there was a conscious component, which might be the funding, right? If somehow that was tied to this and that was actually an external incentive, what other condition, what other terminology might we use? If it's not factitious, what's its related phenomenon?
I know what it is, but I don't remember the exact
Malingering.
name of it.
Right? It's malingering.
Yes,
Yes.
yeah.
Right? Now, interestingly, malingering was removed from the DSM-5. It's put into a more grab bag category of other unspecified. Right? And the reason why is that malingering is not considered, per the American Psychiatric Association, currently to be a mental disorder. It's a crime.
Yeah.
Right? So when you intentionally harm someone for external incentive, it's a crime. That crime is called malingering, but you're not going to find the M word as a diagnostic category in the current revision of the DSM. So we need further investigation as to what was her true motivation. And only when we understand that might we refer her, the mom, psychiatric care, or refer her to the local police.
Yeah. You'd have to know the intent.
But it is suspicious that there is some external incentive that appears to be at play, but that definitely needs to be investigated.
Yeah.
So,
Like as a parent, she could have had like life insurance or something.
okay, 100%. What else?
Oh, I was gonna say, back to the spider bite, I forgot to mention that from what I like found an article that was saying specifically, like with a black widow spider bite, in children, you might also see, and if you're having a difficulty diagnosing, children might also appear as irritable and have diaphoresis. And there's this one scene where you see like a bead of sweat coming down Coraline's face, which I thought was
You
interesting.
really had to deep dive here. That's pretty awesome. I will have to now not only rewatch that movie, but find that scene. I want a screenshot of it.
Yeah.
Interesting.
And it's when she is with the mom towards the other mother, the Bellum, towards the end, that she gets the sweat. Yeah, which was cool.
That's cool. Any other thoughts here? So let's talk a little bit about Delirium. So just to catch everybody up, the character that the group chose to focus on was Coraline. And the initial assessment was that we had a main character that appeared to be suffering from a psychotic dissociative spectrum illness. And inasmuch, we thought to begin our differential from the perspective of schizophrenia. That was our arbitrary choice from which to work. With regard to schizophrenia, we then acknowledged that this condition was a diagnosis of exclusion, and that we had to rule out psychosis due to an underlying medical condition, the direct physiologic effects of a substance, primary mood disorder, schizoaffective disorder, as well as an autistic spectrum disorder. We then identified that in terms of an ASD, it truly didn't matter if the prequel to Coraline established an ASD because of her new onset delusions and perceptual disturbances. That is, those psychotic signs would not be counted by a previous or pre-existing condition of an autism spectrum disorder. So it really doesn't matter what the prequel tells us. By the way, there's no prequel. Right? However, the other four conditions remained in our differential, and then our focus really was on a pre-existing medical condition and whether or not there was toxin exposure. That may have been accidental, and there's a conspiracy theory about black widow bite, or it could be intentional toxin introduced by mom, who Coraline identifies as trying to kill her. Brief scene, but there is verbalization. Do you think they're trying to poison? So from that, we may not only have a condition, delirium, right? Underlying medical condition resulting in psychosis, delirium, in the main character, but this also, that is Coraline in the movie, may also be a fictional case account of Munchausen's by proxy in a related character, specifically Coraline's mom. Right, so that's a brief summary of where we are. Did I forget anything? From here, we do need to just owe a couple of minutes with regard to reviewing what Coraline is about, specifically delirium. Right? So number one, delirium is usually defined according to the 4 C's. Right? So it is an acute change in consciousness, cognition, the course, that is the acute change in fluctuating courses defining, and then the final C is the cause. Right? So those are your 4 C's. In 2013, the APA tweaked it a little bit, kicked out 1 C. So right now, consciousness is not part of it, but requires 2 aspects of cognition, right? One being concentration. So there's one C, concentration, replaces the other C of consciousness. So we're still kind of at the 4 C's in terms of just remembering the actual DSM criteria. And then the 5th C will be Coraline, just to remember the case study that reminds us of all of this. Let's focus on the causes. Right? The causes remind us that this is the only condition that does a complete 180. And this time I got my GEO right. There's a complete 180 with regard to how we frame mental disorders. 99 times out of 100, as our current conversation attests, we always look at the prevailing sign as perhaps due to an underlying medical condition or a substance. For delirium, it's the direct opposite. We acknowledge that delirium is always caused by an underlying medical condition or a substance. So it really isn't a mental disorder. It's a behavioral manifestation of a medical problem. Right? We have to remember that. At some point, the APA is going to get that and remove it from the DSM. People who have delirium are not mentally ill. Right? They are physically ill with a behavioral manifestation of that physical illness. Right? So the question then is, well, what physical illnesses could cause delirium? Initial thoughts?
Infection.
Infection?
Metabolic issues,
Metabolic?
drugs,
Drugs?
like medications, as well as toxins.
All of the above. Easy way to do this is to remember the fictional case of a Shakespearean tragedy of Macbeth. Who here has read Macbeth or knows Macbeth?
Some lady,
Lady
is it
Macbeth.
Lady Macbeth, yeah.
Sunlight?
Yeah.
The most memorable scene in the entire tragedy is the quote-unquote sleepwalking scene of Lady Macbeth, which upon further investigation is not sleepwalking. Lady Macbeth is absolutely delirious in that scene. Of all things, a physician observes her and describes delirium. So it's delirium, which is important to recognize because the acronym I Heart Lady Macbeth reminds us of all those causes. All right, so immunologic. Heart as an etiology, for instance, in acute MI, I heart. Lady, LP. ABG, drugs, and YAWS, Y-A-W-S, which is a spirochete infection, so RPR, neurosyphilis. Macbeth, malignancy, ammonia, there's a few C's. Chem 1, comprehensive metabolic panel, and the 3rd C is ceruloplasmin. By the way, with the CDC, think UA as well, right? It's infection. B vitamins, or B vitamin deficiency, EEG. T stands for both TSH and trauma. That's a predisposing factor with regard to Coraline. And then there's a few H's. Head CT or MRI, hypertensive encephalopathy, and heavy metal poisoning. That's your differential diagnosis. When you get a call for someone who's delirious, after you establish safety, the first thing to do, think ABCs. In terms of airway breathing, stat vital signs, and for C, stat EKG. Those should be 1 and 1B. Right? Number 3, is to rule out the effects of drugs. There are 2 withdrawal states that can be life-threatening: sedatives and alcohol. So D in that acronym is number 3. When all of the above comes back normal, right? When the EKG is fine, does not rule in for MI, when there is no acute hypoxemia, and when there's no hypertensive encephalopathy per vital signs, when drugs do not appear to be playing a central role. Number 4 is usually referred to as your routine lab smash, right? Routine labs. And there are 8 of them that we get now when the physical exam does not point us in a specific direction. We don't know where to go. Step 4 are 8 routine labs: CBC, CMP, just urinalysis, that is the 3rd, TSH, B12, folate, RPR, and HIV serology. Okay? Those are your routine labs that you get. When they come back negative, step 5, in terms of next set of recommendations, include pneumonia level. Right, so pneumonia, CT, EEG. When they come back negative, the 6th and final step, everything else. Right, so that's a stepwise progression when the physical exam does not reveal what the potential etiology is. Right, 6 steps in recommendations pertaining to the cause or etiology of delirium, keeping consistent with eye, heart rate, and breath. While you're doing this, so I can tell your medical student to do this, you have to actually perform the exact reason why the primary team consulted you, which is focusing on the agitation, right? Keeping your patient safe. So what's the diagnostic consideration, or what's the consideration here? So always look for the underlying cause, correct it, and then the next step is focusing primarily on the symptoms, that is the agitation. Thoughts?
Like for just treating the symptoms, that's next step, yeah.
How do you do it?
So, you can use like an antipsychotic for agitation, like Seroquel or something like that.
Right. What you have to remember is that all of I, Heart, Lady, and Macbeth leads to a final common pathway of lowered central nervous system acetylcholine, resulting in those abrupt changes, those acute changes of consciousness and cognition. So there's a couple things to consider with regard to its equilibrium, that is acetylcholine's equilibrium in the brain with dopamine. Because if I, Heart, Lady, and Macbeth results in lowered acetylcholine levels, you could either inhibit acetylcholine esterase and bring it back up, or you can also lower dopamine and reestablish the equilibrium. For some reason, the data on the acetylcholine esterase inhibitors are not good. They're very inconsistent. So the primary objective is to lower CNS dopamine. And those anti-dopaminergic agents are called antipsychotics, which is why the psychiatrist is consulted. Right. So with that context, what antipsychotic do you think you would recommend? Where did you start your case formulation, and single best answer, antipsychotic to use, and why?
In Coraline specifically, right?
Oh, no.
Oh,
In real
okay.
life.
Well,
So I
so
guess,
I
I
would
guess for
say,
Coraline, we're given an antitoxin? Like
Well.
one example.
oh, I have a couple more thoughts on this whenever you're ready to hear them. But yeah, so you fix underlying condition as far as giving like a psych med. I know like what I've been seeing recently is we've been using a decent amount of like Zyprexa.
Zyprexa?
Yeah.
Any other thoughts?
It would also depend on if they could take PO or not, like if
Okay.
they were capable.
That's true. Let's say right now, just for discussion purposes, they can tolerate PO. All right? Again, I, Heart, Lady, Macbeth resulted in lowered CNS acetylcholine. You've got this, and you want to lower dopamine. What's your single best choice of agent?
Haldol?
Why Haldol? That's right.
The strongest and it acts quicker.
It's true. What else?
I mean, it's gonna act on both of those, I guess.
Which one do you want to act on?
No.
I mean, it'll act on the dopamine.
Okay. And which one don't you want to act on? Acetylcholine, right?
Yeah.
So what you're telling me is that you want an agent that lowers dopamine with no anticholinergic side effects.
Yeah.
That's Haldol. That's why you've chosen that. That's why you've chosen Haldol. Now, the additional benefits, you're right. Haldol is available IM and IV as well.
Yeah.
But the real reason why you're ordering it, the real reason why you're recommending it and using it is because it is that high potency conventional antipsychotic. It's another way of saying that it will lower CNS dopamine without further lowering CNS acetylcholine. That's the reason why. Right? There are 3 conditions when consulted that we have to consider that even though our first thought is Haldol, we quickly opt for another. So outside of a Haldol allergy, what 3 conditions will usually result in our thinking of Haldol, but then moving away from it and ultimately recommending another antipsychotic?
QT prolongation.
Which antipsychotic in the literature has shown to prolong the QT interval the least? Good. Okay. Number 2?
Parkinson's?
Parkinson's. Be careful. Shelf exam. There's 2 ways the question stem may be worded. Which of the following medications' mechanism of action is most appropriate with this scenario? Because what you're looking for here is the agent that binds to the D2 receptor most loosely, right? Which agent is that? Clozaril. Now, clozaril is a second-line agent because of the side effects, so if the question stem instead reads, what is your agent of choice to treat the patient? You're not going to choose clozaril. You're going to choose the next best, which is a first-line agent, which is what? Quetiapine. Right, so just be careful the way the question stem reads when treating delirium in a known Parkinsonian patient or a patient with Parkinson's disease. Clozaril, if they ask about the mechanism of action, if they're asking you what agent would you use, what is the agent of choice in the current scenario, it's going to be quetiapine, which is Seroquel.
I just have a question. Actually, I don't know. Would it be different for children specifically?
I have no idea.
Okay.
Yeah.
Just given
Dr. Lowry is here
Coraline,
today.
I'm curious.
Dr. Lowry is here today, we can answer that.
All right.
Third medical condition, other than QT prolongation, other than Parkinson's disease, in which you're probably not going to choose haloperidol, but instead choose either olanzapine or risperidone. Epilepsy. Right? All antipsychotics can lower the seizure threshold. The 2 in the medical literature that lower it the least, or the lowest incidence of lowering, is olanzapine, and a close second is risperidone. Right? So those are 3 scenarios that you have to think through and usually opt out of haloperidol, otherwise Haldol. The current standard of care, APA guidelines, is that you only provide a PRN. If your patient tells you that it's not working, and the way they will tell you is that you're requiring multiple PRNs after 48 hours, or if the agitation is severe enough, at that point you will add on a standing dose. Right? So it'll be standing plus PRN at that point. Right? Standard of care, serial EKGs, close monitor, whether you do it weekly, whether you do it daily, has everything to do with cardiac risk. Okay? Established coronary artery disease or equivalent, stroke, etc., daily. 2 cardiac risk factors or less, weekly. Because of the risk of QT prolongation with electrolyte abnormalities, daily electrolytes is also recommended, close monitor and correction. Questions? That's the uber quick primer on delirium. Before we end, further conspiracy theory?
Yeah, so you know how the belt has that like bustle on the back of her dress. Like her dress is mostly black, but then like there's like a bustle on the butt area. On the underneath side of that bustle is red, and you like see it occasionally, which very much would mimic a black widow spider, and like the lower portion in the red on the back, which I thought was interesting. Also, black widow spiders are known for like cannibalizing, and which is interesting because they'll say like, oh, when she's having the discussion with the cat, like what mother would eat their child? And like a black widow spider, if doesn't have enough nutrients, would maybe eat like a few of their offspring to be able to provide for others or to create new, and also is known for eating the male mate and like the husband for her. When like Coraline Tate is trying to get, when he gives her the eye, is like eaten up and like swallowed up, which was interesting.
What'd you do last night?
What?
What did you do last night?
Actually, I watched this in between a couple of or sort of like watched it while pausing in between lectures yesterday for didactics.
That's great.
Yeah.
All right. Any final thoughts or questions? All right, guys, grab lunch. We'll be back here at 12:30, half hour, to have film discussion.